Welcome to Distance is No Obstacle, a medical education podcast aimed at providing bite-sized education and information for people working in rural and remote Australia.
Welcome, everyone, to our podcast of Distance is No Obstacle. And this is the topic for today is understanding neurodiversity in rural practice, specifically autism spectrum disorder, or ASD, and ADHD, attention deficit hyperactivity disorder in particular. So we're going to explore the complexities of assessing, diagnosing, managing, supporting patients with these diagnoses, particularly within rural general practice. I'm your host, Dr. Lynn Arias, Rural GP Locum, and I'm joined by Dr. May Su, who is an Adjunct Clinical Senior Lecturer in the School of Medicine at the University of Notre in Australia, and Dr. Sam Ognenis, who is a GP in the Perth Hills with special interest and experience in the field of managing patients with neurodiversity. So welcome to you both. So could each of you tell us a little bit about yourselves and your interest in the field of neurodiversity and clinical practice and the roles you currently have. Sam, you want to start?
Sure. Thanks, and nice to be with you. So I am a fellow GP working in general GP, but with a particular interest in mental health, which has sort of evolved over time from hospital years through to training and fellowship in the community. That to a large extent has just sort of evolved organically over time, but definitely an interest. And then seeing patients as you go along, you get certain groups of patients that are maybe stickier to you in terms of who continues to see you longer term and how you practice. And over time, that has included lots of patients with neurodiversity, particularly the conditions you mentioned earlier, ASD and ADHD, but there are lots of others as well, which I'm sure we'll cover, and find that the assessment and management, both alongside specialists and individually, to be very rewarding and enjoyable. Right.
So May, thank you very much also for joining us. Please tell us about your experience, not only as a clinician, but also, as you have said to us beforehand, that you are also a parent of a neurodiverse child, and that would certainly color your experiences.
Thank you very much, Lynn, and it's lovely to be here together with the two of you speaking on this really important topic. So I'm an academic GP, so I work 2 days a week clinically in the inner city of Sydney. So I'm based on the Gadigal lands of the Eora Nation, and I work with specific interest in complexity, abuse and violence, mental health, and neurodiversity. My academic work, I'd always been interested in mental health, recognising it was a significant gap. And I started off in my academic role kind of accidentally, recognising that I didn't know much about some of the presentations which were coming my way and wanted to learn more about that. And then accidentally did a master's and then accidentally decided that I would study more. But I think it lends itself very well to the clinical roles, which of what neurodiversity is actually part of. And it's really interesting because I was an academic before I was actually a parent. And so I would have considered myself quite expert in mental health, and I would have considered myself, my master's actually included psychotherapy and child and adolescent development. So I would have thought I was good at that before I parented. And then my child was diagnosed with neurodiversity as a later part of the journey, and it did take us some time to actually work out what was going on. And I think for those of you who are listening to this podcast, some of you may resonate with this from your clinical experience and working with patients, or some of you may have your own experiences as well. It's very different being on the other end, living through the diagnostic process and support for your child. But I would say that it's made me a richer clinician And I do think back on those times when I thought I knew this topic, that I think you actually realise that I think for many of us who do work in this field, there's still a lot more that we are still learning about neurodiversity and how to best support people who have ADHD, autism, or any of the other co-occurring presentations as well.
Thank you very much. So why don't we go back to what do you do when someone walks in and says, I think I may have ASD or I may have ADHD? What do you do?
Yeah, no, that's a good question and very relevant. And I think everyone would have had that experience at least once, probably multiple times. My general approach is to try and gather as much information in that appointment. So treating it almost like a first mental health consult of any sort. And sometimes we're talking about other things, and the topic of ADHD or ASD might come up. And so there's a sort of overlap of patients who might come with that as the primary reason for attendance or as a second or third point on the list. And then there's others who it's not even on their radar at all. And you're actually the one raising it, which is an interesting thought. And we'll cover it, I'm sure, a bit later. But the person that has already thought it through, generally speaking, people don't put these thoughts together and book to see a doctor and present that information without having given it a bit of thought beforehand. I don't know, Lynn, your experience I'm sure is similar. Often people have actually raised it a couple of times before, perhaps other GPs or psychologists or friends, colleagues, parents, whatever it might be. And so just listening is often very useful. And sometimes it's fairly obvious that they're correct. And sometimes it's a bit less clear, but we ought to be able to hear things. And regardless, there's been some sort of symptom or some sort of idea that has brought them to that. So whether it's symptoms that might be consistent with one of these conditions, it might be a family member who's been diagnosed perhaps, or it might be struggles at work, struggles in a relationship, whatever it might be. And so whether they end up being diagnosed or not is kind of besides the point, because you'll help them with those symptoms. But as I say, very often there's a pretty good sensitivity and specificity often with these things. And so how I generally approach it, as I said, is hearing things through, just letting someone talk and trying to make sure we get a bit of a longitudinal history. So looking back over different situations. So if they can remember back to primary school and high school in terms of academics and socially, then what do they do after high school? That's find that transition point to be quite useful in terms of further studies, work, apprenticeships, relationships, moving out, all these kind of things, either as a positive because they got out of the sort of school system where they might have been a little bit trapped in and it wasn't best for their brain, but they moved into an apprenticeship or a job that really stimulated their brain and they thrived. Or the opposite, where the rigidity and structure of school and living with parents or family kept a lot of these symptoms in check. And then the enticements of adulthood and living alone and being away and having to do a lot of things yourself and self-directed learning and studying and working has meant that those factors are not there and their symptoms become a lot more evident at that point. So they may have been there from a younger age, but they just weren't as evident or problematic until adulthood or other transition points. And so trying to get a bit of that history and then, acknowledging what they're saying and making sure you're ruling out other things or getting at least some organic screen done in terms of some blood tests, just simple things like you would do with other mental health.
Can we jump into that about, what are the comorbidities that are common with neurodiverse patients? Or as you've said, other aspects of their life, other factors that could be creating this history, creating this behavior?
Yes, I think and this sort of dovetails with the idea of overdiagnosis and underdiagnosis, and I feel it's important to readdress that elephant in the room early on in terms of we know that certainly there are many groups within society, Australia and worldwide, who are underdiagnosed relative to what we would anticipate the prevalence to be. So girls and women would be a big example, but certainly different ethnic backgrounds, people who don't speak English as a first language, and people with sort of the more masked or high functioning. I use those words with inverted commas around them. They're not my terms, but in terms of where the symptoms may not be as evident in childhood, and so those groups can have just as much of the side effects and suffering, but are not being diagnosed and treated, and so those comorbidities relate to that in terms of anxiety disorders, mood disorders. We know self-harm and suicide rates are a lot higher in patients with ADHD with or without diagnosis, and then flow-ons to financial, economic, relationship and forensic issues that can arise. And so the comorbidities that come with those, particularly in this case, if someone is undiagnosed or later diagnosed, then that can definitely be a big part of that. But at the same time, if you think about how the symptoms present, the impact that would have on other health conditions. So someone doesn't have a condition, but over time they're struggling with motivation or forgetting to do something, exhausted at the end of the day. Are they eating well? Are they brushing their teeth? Are they getting the checkups done? Are they doing these things? So, just anything really that might be otherwise going by the wayside in terms of dental things, eyes, ears, lifestyle factors, drugs and alcohol. So these are both comorbid and also the consequence of untreated or undiagnosed ADHD. And so someone who's identifying can actually treat those as well.
So remember, they've booked a 15-minute consultation with you.
Yeah.
So
I wonder if I could add something to that, if that's okay, Lynn?
Absolutely.
Yeah, and thanks, Sam. That was beautifully comprehensive. I think your patients are in good hands there. I thought I'd just also consider that we do have a lot of tools that I guess we are using for ADHD assessment. And so I know that there's a lot of questionnaires which are being used both in the assessment for children as well as for adults. But I think what Sam's discussion really highlighted was it is ultimately a clinical assessment. So regardless of whatever questionnaires are in use, it's actually all of those things that Sam mentioned, which actually enable us to be considering how likely this is to be ADHD plus or minus potentially another co-occurring presentation as well. So I just thought that it was really important to raise that, particularly now that GPs are likely to potentially prescribe, that we need to actually make sure that we remember that we're already good at this. We already see people who present with, I would probably say, Sam, often what I might be seeing might be in children, often difficulty functioning at school, or in adults, often with a mood disorder. And I think mental health ends up being a bit of a catch-all for everything. But actually what you're often working out is what else could be going on. And I guess what we really want to make sure is that particularly in someone where it's not a straightforward presentation of a clear precipitant for why they're in the mood disorder and a clear resolution of that maybe there might be something else which is going on, of which ADHD might be one of those things.
So, May, that's
Agreed.
Terrific. Could you actually specify or give us some names of some of these screening tools and where GPs could go to find them? I know that the college has run a continuing medical education program that people can log in for, and they list some of the screening tools that are used there. So from a practical point of view, what are things that a busy GP could download and potentially say, look, I would like for you to fill this out and bring this back in, or could you sit with my practice nurse and fill this out, and then I'll see you after I see my next patient? Because clearly, and this goes back, Sam, to your discussion, there's a lot of stuff to cover, and you're going to want to see these people back, probably for a long appointment for the next time. And we're going to want to involve other support of other practice staff, potentially family, friends, etc. So getting back to the screening, what are the ones that you would recommend, May or Sam?
So there are several. In adults, there's the ASRS, Adult Self-Report Scale. There's lots of places you can access that for free. Some that are you can send a link to a patient, you can print it and sign it, whatever works. Some of the patients have discovered that themselves. It's, if you're typing in, adult self-check into Google, you might come across it. So that's a pretty good one to start with. And then, but as I said, I generally send people or work through the other ones that you might see, DAS-21, K10, PHQ-9, these sorts of ones. So again, looking at
general mental health. Yep.
Yeah. And then in kids, so ASRS, although it's adult, I'm comfortable using that in sort of kids that are maybe 16 and up. And then in kids younger than that, you're particularly looking at parent and teacher reports. So there's things like the WRS, WRS, WEISS, and I'm sure we can include some other ones in the notes as well. Some that are a bit more parent specific or teacher specific, and sometimes the ones that have the child giving a self-report as well. And I agree with both of what you said. The first appointment, as I said, it's more about listening and getting as much down. This is going to take some time, and I would preface that by saying that often these patients have been diagnosed with other things before, or if you're not spending the time, they'll be diagnosed with something else and go down a path of treatment, whether it's medication, psychology, whatever, that may or may not be very beneficial. And so, you end up spending time, and they spend time and money going down that path. And so, yes, it's a bit of work initially, but if you spread it over time, it doesn't do too much in one sitting, and it allows you to give them the questionnaires and come back and chip away at it over time. It's not a rush to diagnose typically. It's not a rush to get referrals in. There's a long wait usually anyway, but you can get to the answer. And so investing that time, but using practice stuff, as was said, using questionnaires the patients can do in between times, if you can, is definitely my approach as well.
Excellent. Thank you. How about you, May?
And in answer to where you might be able to access them, the RACGPs actually developed 2 very excellent modules as well. So you should be able to access the rating or screening tools that Sam mentioned as a list available there as well, which is helpful. And that's quite useful because it's kind of got a downloadable resource which actually links you to some of those tools. I guess, one of the concepts that I've often used is this concept of a formulation, like what brings this person to your rooms asking for a particular thing that they want help with at this particular point of time. So if we can just kind of keep that in our minds every time we're seeing that person, it kind of helps with us kind of being able to be having the same agenda about
Absolutely.
what we're working towards. Because what you might find is they may have their own considerations about why they've come in to see you, particularly I'm sure, Sam, they might be coming in to see you particularly because they know you work with ADHD, and similarly for me, they often come in knowing that they specifically want to see me for a specific purpose, knowing that I work in this area as well, and that might be the case for many other GPs out there. Or it may be that they're not sure how to navigate the health system. So they're really just trying to work out where to start. So working out where their understanding of the process is can help. But sometimes you might be doing that before you even get to any assessment tools or screening tools. I would probably comment for myself, I would spend a lot more time in that initial formulation, which might take 1 or 2 visits. Before I would even get to using any tools, because there are a lot of tools there, and each of the tools really just gives you some specific information. So you need to know what's the purpose of why you're doing this tool in the first place. It can actually, for some people, can be triggering to actually complete some of those questionnaires. So, you do need to just work out that you're doing that purposefully. As well. Plus, for some of them, so for some individuals who may have communication difficulties, they may actually need assistance to complete some of those questionnaires as well. So there's a lot you can do before you even get to the point of completing some of those tools.
It's always an excellent question to ask patients besides, what can I help you with today? Is go, oh, well, this sounds like this has been going on for a long time. So what has motivated you to come in now to address this? It's such a bit of a pearl for us because, as you've said, May, it allows us to connect with what is that person actually concerned about, how is this affecting them, why now? And then we can kind of stay on board with them, moving in the direction that they want to go in terms of having this diagnoses addressed and managed.
Yeah.
So, and certainly the take-home message here is even if you haven't got a lot of appointments in your schedule, these are people that are going to take time. You're going to need to see them back, and there isn't a hurry. What's important is that they've started moving in this direction, and they know that you're interested in helping them. I think it's important that to understand that there will be GPs who may not feel comfortable being in a more active role in diagnosing and managing and potentially treating people with ADHD and neurodiverse conditions, and that's okay. What matters is that we think it as a possibility in this person's diagnostic options, and that even if we don't want to manage it, that we can at least make a diagnosis or a possible diagnosis and refer. Would the two of you agree with that?
Yeah, very much so, Lynn. Plus, I'd probably also make that comment that even in the process of referral, like if you're doing that together with the person, that can be a very therapeutic process.
Absolutely.
And it's quite common that when you're starting to get into complex presentations, that often work occurs in a team. And I know that whilst there is legislative changes which are occurring where GPs might be managing some of the more straightforward presentations, I think in general practice we see the breadth. And so we might be seeing some people who are going to need multidisciplinary care as well as one's presentations that we might be managing mostly by ourselves. And in those contexts, well, just I hear what you're saying, Lynn, about every GP can have different breadths of what extent that they may be managing this kind of presentation. Though I do think we need to be mindful that I think every GP should at least be considering that this is a potential diagnosis. Because I think if you're not thinking about it, well, you actually shut the door for that person potentially getting assistance. And I think sometimes that means even if you might not have the tools to be able to diagnose the person, at least walking along with the journey with the person as they're on that recovery journey can also be a therapeutic process. And you might learn things along the way, even if you don't feel skilled at the time about it.
Absolutely. I'm curious with both of you, what ancillary or support staff do you use in your practices that help you with managing these patients?
I definitely, and I fully agree with May there. The stats you pointed out earlier, Lynn, about that sort of roughly 5-ish% of people with ADHD and roughly 1 to 2% of ASD. If we're thinking type 2 diabetes, around that 5-6%. So it's would it be okay to say, well, don't do type 2 diabetes? So that wouldn't be a good way to approach it. The assessment part and doing those extra training, absolutely, that would be optional. And that not everyone needs to be doing that. It's more like having these patients, you will have them already, and they'll have other conditions that need to be managed alongside. This is more just being aware of that would be the other thought. In terms of involving other stuff, I tend to make sure patients, when they leave that first appointment, have their second and or third appointment with me booked, whether it's a week, 2 weeks, 4 weeks, whatever we've agreed, and just book those in and have those reminders set. I think that's really important. And I think having reminders on the system, so depending on what software you use, particularly once people are diagnosed and are on stimulants, having a sort of recurring sort of every 3, 4, 6 month, whatever reminder about, medical check-in or blood pressure check or whatever, which is ostensibly to check those things, heart and blood pressure and appetite, eating, weight, bloods, whatever it is. But it's also just a way to check in general. Sure. So, trying to get people in other ways, and then you can cover a lot of the other preventive health stuff, as well as the monitoring of the condition and the medication. So utilizing the software like that, I tend to find to be quite useful. And also within the practice, depending on what you have, you might be utilizing your nursing staff or colleagues. So, having a buddy who also has an interest and sees lots of patients, if you're on leave or they're on leave to, for when things pop up, to be able to give you some options there as well. And then within the waiting room, so office waiting room, you can have either some resources around or, links to support organisations. So in WA, we've got ADHD WA. Nationally, there's the ADHD Foundation, and there's lots of ones internationally that have relevance to Australia as well, and resources and references. So you can be utilising those things. I probably don't utilise that as much as I probably should. That just depends on your setup there. But I think it's really important to just have a thought about those things, not cluttering too much, but having the opportunity when the person is there and you have a captive audience to kind of utilise that. And trying to do as much as possible. It might be they need their ECG done or their blood pressure done, and they could book with the nurse before seeing you for 10, 15 minutes. Or, periodically, if you're running late, they could, potentially go and see them and catch up at that point. And certainly if you have a pharmacist or a medical student or a registrar, it can be really, really eye-opening, enlightening, and a great learning experience as well.
Thank you. And something that really resonated with me is that if possible, to get a colleague to also see the patient. So there is continuity of care even when one of you is not there, if at all possible. And of course, for some rural practices, it's not possible because there's only one GP. And sometimes they will be away because they have a right to be away on holiday or study or illness. But if you can share kind of the workload and provide that continuity, to me, what I hear is that there are really two benefits. One is that patient doesn't have to tell their whole story again, and it's not a new face each time. But the other thing is, and I'd really like both of your opinions on this as clinicians, is these patients can be quite challenging and exhausting, potentially, to manage. Not only because of behavioral issues, people will have a lot of fear around the potential diagnosis, what can be done about it. And these are lifelong diagnoses. As far as I'm aware, people don't stop having ADHD as adults. They learn how to manage it. We have medication if people choose to go on it. And people often come along with a lot of emotional issues around it. You've already said, Sam, that you have to think about mental health diagnoses, potentially substance abuse problems. I'm guessing that you would uncover patients with histories of trauma, and abuse. So people can be quite needy, and how you manage that and how you make sure that you don't get burnt out, especially when you start being known as someone with an interest in the area, you start getting more referrals. So how do you manage it?
I'm happy to speak to that one.
Please.
Because that would be the cohort that I do a lot of work with. And first of all, I think, I really like Sam's analogy of the prevalence of ADHD being the same prevalence as diabetes. So we do need to recognise these are high prevalence conditions. And so as GPs, we deal with high prevalence conditions. So whilst we may not be endocrinologists, we still have an awareness of how to manage diabetes mellitus. So it's a similar concept with ADHD, although bearing in mind that there has historically been less training in it. So some of us may be choosing how much that we're skilling up at this point of time, but there does need to be an awareness of it. I think we're also in this really lovely age at the moment where there's also increasing awareness in the community as well. So some of the supports that we might be calling upon are also within the consumer population. So ADPER, as you know, it has a consumer guide as well as a prescribing guide. So and that can can be helpful that there's also an ADHD Australia Association, which is where people can either get supports for their journey and their diagnosis of having ADHD, just as there's Aspect Australia, which has the equivalent with autism as well. I think it's important as clinicians to also remember that we are not rescuing people from their diagnoses as well. There's a phenomenon called Cartman's triangle, drama triangle, where it's quite common that, a lot of general practitioners come into this work being very altruistic and wanting to really fill a need where there may be limited services. And I would comment that ADHD and neurodiversity is definitely a need right at that moment. Then there is that phenomenon when we try to step in and rescue someone from their situation, that we can sometimes disempower the person from their own recovery journey.
Absolutely.
And their ability to actually move forward with what their needs are in their recovery. So I find it's really helpful when you are dealing with any sort of complex presentation to remember that we can, as an expert, assist and guide them with the tools to assist them with their recovery, but we're not swooping in and taking them away from their dastardly lives that they're experiencing. That's kind of not the phenomenon. But it also removes some of the onus from the general practitioner to feel like we're also responsible to hold everything. We don't have to be responsible to fix the socio-economic difficulties that we have in society. We can be there and we can recognise and we can hold the difficulties that that person might be having with that. We can help to advocate, we can help to facilitate people's ability to access care, but we actually don't have to fix things which we don't have power over. So I think that's really important.
I agree.
Particularly situations like this where it's still evolving about the support structures which will allow us to do this work. And I think this goes back to your question about teams. Some of those teams are going to be non-clinical teams as well.
Absolutely.
Like it may be about how we assist people with housing, how we assist people with social prescribing to get more integrated into social groups which are more in tune with their values, or get them active in ways which maybe they were having difficulty with an exercise physiologist. If we bring it back specifically to ADHD, and I often link ADHD and autism together because they are so commonly co-occurring, but I think we do need to be mindful somebody might only have ADHD or might only have autism. But some of the services can overlap. And one of the diagnostic criteria for ADHD is that the person may have inattentive type or hyperactivity type. And so the inattentive type might mean that organisationally it might be challenging for them to be able to engage with your own organisational processes. So that means within your practice, you might have to set up some systems to make it easier for that person to be able to engage with even your own health systems, have recourse systems, have a process that, you're remembering that what happens if somebody doesn't turn up, maybe they need a bit of assistance to get to you. Or if you have someone who has autism and communication, so with autism, it's communication, social, their difficulties with functioning might be along social and communication or restrictive and repetitive behaviours. So recognising that your staff might need some training about how to best engage if they're making appointments or they have difficulty navigating those things. And Lynn, you also mentioned trauma, so I do a lot of work with trauma as well. And there's a very big overlap with complex PTSD, trauma and PTSD, which may be because I think historically we have not been very good with managing neurodiversity. And we haven't really mentioned this, but ADHD and neurodiversity is very much, it's not fully biologically driven, but there are very strong biological predeterminants to whether someone actually has this presentation. These are considered neurodevelopmental conditions, which means there is something about the developmental process which is actually part of the presentation. And so what that often means is that families often have neurodiversity, and the families may not have always had very good support in their diagnosis and presentation of neurodiversity. So you may also be navigating those aspects, which it may not be intentional, but that chaos and that difficulty with having had care within your family system may also be traumatic itself. I call it often the trauma of identity, when you still don't quite, you're not necessarily validated for who you are in yourself as an individual, and so that itself can be a traumatic process.
Absolutely. That's
Yeah,
very
not
powerful.
to mention the other sort of common biological co-occurring presentation. So it can be any neurodevelopmental presentation, which ADHD and autism are the most commonly linked presentations, but you can also have learning disability as well. So we do need to keep an eye out for presentations like dyslexia, dyscalculia, and about hypermobility is increasingly being recognised as a co-occurring presentation. So the population prevalence for hypermobility is 4% of the population. In a neurodiverse presentation, it's 40%.
Wow.
So, we do need to be mindful that actually there might be some other reasons that people might be having difficulties, and some of that's actually physical and biomechanical. Plus, if they're going to have sensory sensitivity, which sensory sensitivity can occur with any neurodiverse presentation, well, that's also going to make it sometimes a little bit different in how somebody engages with the external environment if their interpretation of senses is going to be different with the external environment, let alone their interoception, which is their sense of the internal self as well. Then you also throw in other psychiatric conditions like there is an increased prevalence of psychosis or psychotic disorders like schizophrenia or bipolar affective disorder, and epilepsy as well as tics and Tourette's. So plus increasingly we're also recognising autoimmune conditions as well. So if you have a hypermobility disorder such as Ehlers-Danlos with the connective tissue disorders as well, then the other rare syndrome, but not so rare in this presentation, is also mast cell activation syndrome as well. So we do need to just be conscious that there might be, once you start accumulating diagnoses, you're actually a bit more likely to consider other presentations. And 4% of the population also has a rare disorder, so often chromosomal. But for a lot of people with chromosomal disorders, a neurodevelopmental disorder like ADHD is actually much more likely.
Wow. Thank you for that. That's very that's extremely useful in helping us think broadly, think longitudinally, and to get other people involved, and whether it's psychologists or community organizations or a family member to remind people that they have an appointment, to get our staff to also think how we best need to support these patients. We're very good if someone is limping, a staff person will go run out and bring in a wheelchair, right, and help them bring into the practice. Mm-hmm. But when someone has difficulties communicating, we just think they're a bit of a problem at the front desk, or that, they didn't show again. And how you've described really how broad-reaching and how how linked so many aspects of health are, and to neurodiversity. It really means it is, it behooves us to think broadly and to see these people over time. For people in the country, that can be very difficult. One, because, Sam, you said, I'll get a patient to see me next week, and I'm having a bit of a giggle because I work in lots of places where if there is a GP there, they're booked up for 4 weeks solid. So that is not possible to see them on a weekly basis. And the other thing is there are many practices that rely on locums, and they're not going to see the same person. So then it brings up the possibility of, can you use telehealth? And how useful is that? But the issue is you will not be able to have that kind of sort of weekly follow-up, and often not with the same person. And that's just the reality of the distance. I guess I'm thinking that's where if you can bring in your specialists, like your psychologist, potentially your speech therapist, physiotherapist, things like that, at least people can have continuity with those people, and their medicals review are a bit potentially further apart.
I totally agree. I think maybe I was a bit optimistically.
No, I think you're
that
greatly
weekly.
resourced. I think it's terrific.
I think to I think Lynn's covered it. I think May's covered it in great detail, and I think some really great pearls. If I give some sort of like brief examples of what I might do, because I can understand someone might be thinking, oh gosh, this, we understandably, we don't want to have the practice only set up for one group of patients to the exclusion of, so so as you said, if someone's limping, we'd have these. So it's just having these things around. Honestly, a lot of simple things that I would do is, so say, for example, booking patients sort of at the start or end of your session, particularly like at start of your like lunchtime, afternoon session. So particularly people with, sensory difficulties, you've got a big open waiting, or if they're coming in when there's maybe only one or two people there, you're going to grab them straight away and they're going to go out the door. Like that can be an easy thing to, so they're not having to spend a lot of time waiting and around lots of people. And that's something that, doesn't specifically require any major setup, just thinking of that. And honestly, using telehealth, I was going to say, sometimes, if the person hasn't shown up, but you think maybe they just didn't, see the reminder, or they're, stuck in traffic or whatever, it's not uncommon for me to just call them, and if they consent to discuss things via telehealth and we can continue the chat, great. Obviously, if they're not happy, then that's different. But sometimes it's just, flexibly pivoting and just calling and doing it via phone, and we'll see you in person next time kind of thing. It's not the end of the world necessarily. It's just, doing those things where, you can just be sort of quick and practical. And rural GPs are not only extremely experienced and wise across many areas of medicine, they're also very practical, pragmatic people. And so this, I feel, speaking to that of, you don't have to do anything too specific or dramatic necessarily in your own practice, your personal practice, but also the practice itself, to have a better uptake of patients and the care needed. The other thought, I guess, from what we were talking about before, is just having those appointments structured and built in, even if they are every 4 or 6 weeks. If they miss one, then there's still one in 4 or 6 weeks kind of thing. Especially if they're seeing a psychologist or whatever it might be, then they're not necessarily missing it altogether in that time frame. And so just having those sort of preempted, like you would do with an older person with various chronic diseases, or someone who's on opiates, say, and then you're seeing them monthly. These sorts of standard principles that we do in lots of other cases is just having the same kind of idea. And as you both pointed out, having a backup for when you're away, or having a thought of of what you're going to be doing, whether it's extending out for 2 months or getting to see a colleague, or seeing you a bit sooner and they just missed that month, and whatever it might be. But just having a bit of a think about that, as you would already be doing with various other conditions as well.
Great. May, did you want to ask something or add something?
Yeah, I was actually going to comment that often the adaptions that we actually put in for a neurodiverse person are actually often the kind of adaptions that a neurotypical person wants anyway. So, there's a universality to actually these adaptions, which I actually think are probably useful for us just putting in place regardless. I mean, the way that I often think about, and I might speak to autism here just because I think that's where the social communication issues become probably the most problematic. The way that I often think about it, and this, I remember reading an article about this one time and it really resonated with me. There's this term called double empathy, where often the person who is autistic actually has more understanding and awareness of how a neurotypical person functions, because they've had to learn how to adapt to the majority of society and how they've had to function, compared to the likelihood of a neurotypical person actually adapting to someone who's neurodiverse. And I think that probably is probably quite true for what I've seen. But the way that I often think about it is, for a neurotypical person, most of the way that a neurotypical person sees the world is actually often through those social interactions. So they form social connections. Their values might be held by what often gets driven by the social interactions and relationships that they build and develop. But I think for an autistic person, it's not like a person who's autistic doesn't have empathy. They certainly often can be highly empathetic people, and often more so than some of than some of the other patients that I have. But I think the world views that I see it's often constructed by rule So the world functions this way because people say hello because they always say hello. So functioning outside of that can not work, because then it breaks the wall down, and so the whole world construct falls apart. And so it can be why when someone's saying, I don't know what to do, this is a very common thing I often get with my neurodiverse patients. I don't know what, they're literally saying, I don't know what to do because I literally don't know what you're saying to me. Sometimes it's the meaning of a word. I had someone say to me, because we were talking about training their support workers, and eventually it took me weeks to finally work out they didn't understand what the term training meant.
Right.
So, you know, those sort of things can take quite a bit of time to actually work out that's what the communication breakdown is, because it actually requires actually working out that, like, if you have someone where that sort of interaction occurs with every single interaction, someone makes small talk, they're trying to decipher really hard about what that small talk means.
What is really going on here.
What is really going on. Even if they can manage it, it's very tiring and very fatiguing. And so that's actually where often then the meltdowns occur, because they're just so exhausted from having to do so all the time.
So what I'd like to wrap this up, and I thank both of you so much for sharing your time, your experience, and your expertise. I think there's some great information out there for practicing GPs to think neurodiversity. There are tools that people can download. And then within the resources of your own practice, and of at least now that you're thinking about it, what can you now do about it? Whether people choose to take on the prescribing role, say for ADHD, that will be up for them. Sam, I wonder if in closing you might just talk about what programs are available for people who do want to upskill, particularly as you're based in WA, and WA is kind of at the forefront of moving ahead on this. I believe the college is running some program, or perhaps you also can speak to this.
Yeah, so I think it's definitely a dynamic space. So we're recording this on the 18th of August, 2025. So if I'm not correct by the time you listen to it, I apologize. There are a few big changes in WA. The most relevant across the board and actual change is the law around what was called co-prescribing or shared prescribing. So if someone was seeing a specialist, pediatrician, psychiatrist, or sleep physician, neurologist, whatever it was, in terms of their stimulant medication, they needed to see that person annually, children and adults, and that specialist had to write an authorization to the department, including your name or your practice, to be the co-prescriber. And so they would do 6 months prescribing, we would do 6 months prescribing, and they would see them again. The law as of late 2024 has changed to be still 12 months for children, but 3 years for adults, so a longer time frame for patients who are stable dose-wise, and the GP is happy to continue monitoring in terms of side effects, blood pressure, random urine drug screen, these sorts of things as appropriate. But the other thing that changed is that for kids and adults is that you don't need that co-prescriber written, the form, written specifically, so you can just prescribe alongside them as long as the patient still is seeing the specialist within those timeframes. So that's a big change and would definitely be useful. It's still an authority script typically, so you're still calling Proder or going onto the website. And there's also, and so that's without any WA Health involvement, basically, as long as you're prescribing within the limits of what the specialist has done. And there's also Script Check WA, which is another check to allow people to make sure that people are not getting multiple scripts from multiple places, which is, once you get the hang of it, it's pretty easy to use. It can be a little bit annoying initially, but it's not too bad. So that's one big change that people, particularly in the rural communities, it's hard enough seeing specialists in the first place. So this is a change that I'm at least optimistic that it will mean there's more specialist space for new assessments, or to see the patients who aren't stable in terms of doses or side effects and things. And so they need to go up or down in their dose, or they need to manage a comorbid mood disorder, anxiety disorder, whatever it is. Those are not the ones that the GP needs to be doing all those adjustments and sending, and the specialist sees them in 3 years. Those are the ones that, in theory, can go back to their specialist, but not at their pre-prescribed 6 or 12 month interval. They can see them in 3 months and then not for another 14 months or whatever it is. And so that's the hope, I guess, with that change. But it would be naive to think that it would just be easy to see specialists, particularly in the pediatric population. I think that's definitely just still a very big struggle in WA as it is across the country. And so the college does have some modules on the RACGP, like the CPD part of the college website. And again, I'm sure we can do links to those, which are very
through GP Learning.
GP Learning, thanks. So the college has modules through the RACGP GP Learning page. I'm sure we can do the links for, and they're useful. They're limited in some ways, but they are quite useful. And then beyond that, there's lots of organisations, places like ADHD WA, Medcast, these sorts of organisations, Health Ed, who have talks, discussions, presentations, upskilling, etc., that you can do. And then there's further you can go depending on what you want to do, and that might involve being more confident with the prescribing and management of comorbidities, looking at that. It might be looking at non-stimulant medications. It might be these are ADHD coaching and having an understanding of these other aspects of ADHD treatment with or without stimulants. And then from an ASD and other neurodiversity perspective, it's definitely managing those comorbidities, understanding the NDIS, understanding how to assist your patients along with these things, and psychology, mental health care plans, utilising appropriately. And then in the future, we're heading towards maybe GP diagnosis, assessment and management. This has been mooted for a while and there was an expression of interest, but I don't know that anyone's heard anything just yet as I say, today's date. So I'm not sure, but over time that will evolve. Basically, there'll be more. But yeah, in the practical short to medium term, it's understanding those changes. And if your patient's seen their specialist within 12 months or 3 years, then you can continue their prescribing.
Okay, I would like to ask for some clarification. Can GPs actually initiate stimulant treatment without the patient waiting to see a specialist? And I believe it's for
not in WA.
For WA over the age of 10. Is that correct?
Not at the moment. That is what the expression of interest was towards the training to allow that. So I'm not sure exactly how it will look in terms of like within the legislation, or if you get
so at the moment, can GPs initiate stimulant treatment?
No.
Okay.
No initiation, no dose adjustment.
So really at the moment, the advantage is that we can prescribe the same medication for longer. And
Lynn, I would comment, though, that this is rapidly changing. And
each state is also a little different.
That GPs can initiate, but there are currently some processes about how they do that. I would say that Queensland is the most progressive with that, where they can just initiate and prescribe. But in New South Wales at the moment, it can be when they're in a supported a supported co-prescribing situation where they're allowed to initiate. And my understanding is WA doesn't have that yet, but there is a discussion that they're planning on developing a process of that. Unfortunately, I think that there has to be the legislative changes statewide, but a lot of the states appear to be lending their processes based on pre-existing statewide legislation, which is a bit more progressive, of which I would believe Queensland's probably been forerunner with all of this.
Well, GPs have been able to prescribe there for some time.
Yes, that's right. Yeah, so New South Wales is also right in the process of this as well, which is where I'm based. But I think what Sam is saying is that it also looks like Western Australia is also having some similar processes, which is watch this space. And
very much.
I would comment that the modules at the moment seem a bit more basic because they are developed for what they call Tier 1 or Tier 2 prescribing, which Tier 1 is about continuation of of prescribing for a person who's already had a formalised assessment,
Right.
and you're continuing on already a stable process. And the idea being is that I think for most GPs, they're really just going to feel most comfortable with managing more straightforward presentations, but there isn't an expectation that they have to say yes to when it's more complicated to prescribing alone. That generally that we would expect, just as a psychiatrist would, that those people should also be managed in a team. And I think we're just saying that would be very similar, that GPs would manage that in a team, just like psychiatrists would manage that in a team.
Look, thank you both very much. I'm sure our listeners have found this incredibly informative. And I also invite our listeners, if you have ideas about future podcasts or topics you'd like addressed, please just email Rural Health West. We'd love to hear from you. So thank you both again. Let's just move forward and do the best we can for our patients. Thanks again. Really appreciate it. Bye now.
Thank you.
Great. Thanks, mate. Thank you.